This is Selma Schimmel for the group room at the annual San Antonio Breast Cancer Symposium, where we're now joined by Dr. Hope Rugo, Professor of Medicine and Director of Breast Oncology, Clinical Trials and Education Program at the University of California, San Francisco Comprehensive Cancer Center. Hello, Dr. Rugo.
Hi.
Dr. Rugo, what's news with local regional recurrence?
Well, it's an interesting thing. We do a lot of breast-conserving surgery, and even in patients who have mastectomy, they certainly could have a local recurrence. Now, the risk of local recurrence with the increasing use of MRI, very good analysis of margins and wanting to have clear margins, use of radiation appropriately, local regional recurrence risk in general is low. But some people will still have recurrence, and they may have recurrence many years out from their primary tumor that's related to that primary tumor, or hard to say. So the big question for us always has been, if you had original cancer and then you get a recurrence and it's resected surgically, should you get chemotherapy? I mean, you still have the cancer, right, like you did in the beginning, but you already got treated for it. So this trial called the Calor Trial, C-A-L-O-R, wanted to look to see in patients who have a local regional recurrence, if they got randomized, like the flip of a coin, to get chemo or not, would the outcome be different? If you have hormone receptor positive disease, you get hormone therapy. So unfortunately, they really couldn't enroll patients. They originally wanted to enroll almost 1,000 patients, and then they decided they changed their goals. They wanted to enroll 260 patients, and then they only enrolled 162 and closed the trial. So that's disappointing, that you couldn't get people to randomize and enroll on that trial. But nonetheless, they did have some very interesting data. Some of these patients, about 40%, had had a previous mastectomy. They could all have disease that was surgically removed with clear margins. Some needed radiation afterwards, some didn't. But what they found was that as a group of a whole, even though it's a smaller study than they planned, that giving chemotherapy based on the physician choice reduced the chance of recurrence and improved outcome. When they broke it down, that impact was greatest in patients who had hormone receptor negative disease. So if you have ER positive cancer, and you have a local recurrence, hormone therapy may be the appropriate choice. But this gives a little validation. It's not perfect, but it gives some validation to considering chemotherapy if you have a local recurrence of a hormone receptor negative cancer. And I think that's very important data, because even though it's a small study, we haven't had any direction in that area before.
More and more as we look at personalized medicine and being able to identify, the genomics of cancer and biomarkers, let's talk a bit about what's being presented here in the area of biomarker research and the impact and implications that has for treatment.
Actually, there's very interesting presentations here, most of them in the preclinical setting, in other words, either with cells in little dishes or in mice. But there was one interesting publication that actually looked at patients who were on a trial called the ATAC trial. They were all postmenopausal women with hormone receptor positive breast cancer, and they had node negative disease in this particular study. They took a subset of patients who were on a big trial where women were randomized with early stage breast cancer to either get the aromatase inhibitor anastrozole or tamoxifen for 5 years. And they looked at some genes that they had previously identified. So they were called biomarkers, and they were previously validated through other data sets. And actually, there were 2 genes together, and they sound funny, but one is called HOXB13 and one IL17BR. And they made a ratio of these 2 genes, and they added together a group of genes that they've put together called a molecular grade index. And their goal here was to see how it compared to some other tests that we did, and could they predict risk of recurrence in patients treated with hormone therapy. They couldn't really predict any difference between the different types of hormone therapy, always a challenge for us. And then they tried to rationalize this with how much cancer patients had using something called the clinical treatment score. What they found was very interesting was that this particular, and it has to be validated, but it's one start. We're very interested now in trying to figure out which patients who have hormone receptor positive disease are at risk for a late relapse. So we know that about 50% of recurrences occur after 5 years. So who are the patients who should take hormone therapy for 10 years or 15 years? We don't know. You add side effects, so you don't want to just give it to everybody, right? We saw at this meeting that if you extended tamoxifen out to 10 years, that you had less recurrence. Is that for everybody who doesn't get an aromatase inhibitor? We don't know. So what they did actually was they looked at who's at risk for an early recurrence versus late recurrence. And some of our standard tests, like the recurrence score, or even a combination of different markers like hormone receptors and HER2, help to predict the risk of recurrence in that first 5 years. But this thing, called the breast cancer index, better predicted metastatic recurrence from year 5 to 10, so a late recurrence. So this actually needs to be validated, but it's, I think, a really important advance in trying to better understand the biology behind dormant tumor cells that come back later, and how we can identify the women at risk so we don't see these women like I'm seeing in my clinic who are relapsing at 11 and 12 years after diagnosis who got excellent adjuvant treatment. And then one other area which I think is very interesting that filled up a lot of one session at San Antonio were investigators who were looking at various genes that are amplified or increased in cancers to see whether or not they drive tumor growth and might be targetable in triple-negative breast cancer. One area of very interesting research is an oncogene described a long time ago, the first oncogene, MYC, M-Y-C. That's now been associated with poor outcome in triple-negative breast cancer. And so we may be able to target pathways associated with MYC. And 2 investigators reported data where MYC is associated with an abnormality in another oncogene, and then yet a third pathway where we might be able to target it with yet newer drugs. So this is, I think, an exciting step towards understanding the heterogeneity of those cancers and really rationally treating the cancers with the worst outcome.
And how far away do you think we are from seeing this sort of information grow into a new standard of care where all these, understand the one's biology, you'll have this cross-section of compounds to treat these patients?
I don't know, because right now, when we've screened patients for changes in particular pathways and then treated them with agents that affect that pathway, it hasn't predicted response. In other words, you might respond whether or not you have that pathway activated in your cancer. This is kind of an exciting new direction, looking at gene amplification, and it's possible that by looking at a panel of these genes, we will really be able to individualize therapy. So I think what's going to happen is that we're going to see early phase trials, phase 1 trials, in the next year or 2. We already have some. And that maybe in the next 5 to a little bit more years, we will see incorporation of this into clinical practice.
In closing, I just would say that as we make these advances, probably there will be some psychosocial issues, because when a person has a sense of what their potential or their likelihood for recurrence is, I'd like to feel that we'd be balancing the clinical outcome or projection with ways to enhance coping skills and how you integrate your thoughts when you get this kind of information so you have the best quality of life, not just physically, but you have the best quality of life psychically and psychologically.
I think that is just such an important area. I mean, we cannot know for sure what's going to happen to anybody. And
Exactly.
I have plenty of women in my clinics who have very, very advanced disease and are doing beautifully well. So understanding biology helps us to provide the most effective therapy. But at the same time, we really have to support women in our survivorship mode with coping skills, mindfulness, provide the right support. And I think that there are a number of organizations that are now providing more information about that. Programs are providing more structure to this support. And then as we understand more about side effects from treatment and how to help people manage those side effects and recover more quickly, I think we're also working in that direction as well.
Thank you. Dr. Hope Rugo, Professor of Medicine and Director of Breast Oncology, Clinical Trials and Education at the University of California, San Francisco Comprehensive Cancer Center.
Thank you very much.
Thank you.